I'm Dr. Ali Al Muhammad Ali. I'm going to talk about thyroid nodule. There are features which help to differentiate thyroid malignancy from benign nodule. Clinical features. There are clinical features associated with a lower risk of thyroid cancer, include middle age, female sex, a soft thyroid nodule on examination, as well as presence of multinodular goiter. Individuals who are at high risk of thyroid cancer include children, young adult, and older female. A solitary firm or dominant nodule that is clearly different from the rest of the gland signifies an increased risk of cancer. Other features which strongly associated with malignancy include vocal cord paralysis, enlarged cervical lymph nodes, and suspected metastasis. B. Serum factors. A serum TSH level should be the initial laboratory study in the evaluation of a thyroid nodule. The serum TSH level is an independent risk factor for thyroid cancer, with the risk of cancer rising progressively with the serum TSH levels still within the normal range. If the serum TSH level is normal, which is the case for most patients, no further blood tests are needed. If the serum TSH is below normal, a radionuclide thyroid scan should be considered to see whether the nodule is hot or autonomously functioning. Measurement of serum calcitonin is not routinely advised. However, an increased serum calcitonin in patients with a family history of medullary thyroid carcinoma strongly suggests the presence of medullary thyroid cancer. Elevated serum TG following total thyroidectomy for papillary or follicular thyroid cancer usually indicates residual or metastatic disease. See imaging studies. Thyroid ultrasound has become the most important tool in the confirmation and differential diagnosis of thyroid nodules and provides considerably more information than radionuclide thyroid scans. Ultrasound is used to confirm that a palpable neck mass is a thyroid nodule, to measure a nodule size precisely, and hence can be used for subsequent monitoring. It also showed specific sonographic features that are important in assessing the likelihood of malignancy, and it often detects other non-palpable nodules elsewhere in the gland that are clinically significant. I'm going to talk about ultrasound characteristic of thyroid nodules. They are characteristics features of benign thyroid nodules, which include isohyperechoic, spongiform appearance, smooth border or hollow, thin wall cyst, dense calcifications. Features which characteristic of malignant thyroid nodules include microcalcifications, irregular borders, hypoechoic, increased internodular vascularity. In patients with low serum TSH levels, radionuclide thyroid scan with 123 iodine or 99 m-technetium pertechnetate can be used to identify whether nodule is hot or cold. Hot nodule takes up more radioactive materials than the surrounding thyroid tissue, whereas cold nodules take up less radioactive material than surrounding thyroid tissue. Hot nodules are almost never malignant, and 5 to 10% of cold nodules may be malignant. However, 90 to 95 of cold nodules are benign. On the other hand, thyroid scans are rarely helpful in patients with normal or elevated serum TSH levels. D. Needle biopsy. Fine needle aspiration biopsy of thyroid nodules to get cytological material for pathological examination is the principal test to differentiate between between benign and malignant lesions. If the nodule is cytologically malignant or if the reading is suspicious for malignancy, the patient is generally referred for surgery unless there are other serious medical problems associated with high operative risk and or a prognosis much graver than thyroid cancer. If the nodule is cytologically benign and neither local compressive symptoms nor hyperthyroidism are present, only reassessment of nodule size in 6 to 18 months by physical examination and or ultrasound is required. If the nodule grows, defined as an increase of 20% or more in 2 of 3 dimensions, repeat fine needle aspiration biopsy and cytological examination may be indicated to verify the benign diagnosis. However, in this situation, the original benign results are confirmed 98 to 99 of the time. In patients with cytologically indeterminate nodules, a radionuclide scan may be obtained if the serum TSH is at the lower end of the normal range. If the scan reveals the nodules to be hot, means that functioning and suppressing the remainder of the gland, the patient can be observed to detect further overt hyperthyroidism. If the lesion is cold and in all other situations where the serum TSH is within normal range, both surgery, which is usually diagnostic lobotomy, and molecular testing are reasonable options, depending on the patient preferences and other clinical features such as patient age, the nodule size, and sonographic features. On the other hand, if an indeterminate nodule is less than 1 cm in diameter, observation with serial sonography is reasonable, with surgery only if the lesion grows.